Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester. Danny, how are we doing today?
We're doing great, Ed. How are you?
Doing good, man. Today, we're going to talk about Ketorolac for pediatric patients. This is a study that has come out. This is coming from, and this is Dr. Hussein, I believe, is out in Egypt. So here we have a whole bunch of different people. We have people from St. Christopher's Hospital from out in Philadelphia. We have people from Cairo. We have people from Gaza. We have all of this is, again, not an American study, but what they wanted to look at here was using Toradol as an analgesic alternative over opiates in kids. So this is a meta-analysis, which, you know, we love meta-analyses here. And so they included 24 studies in this systematic review, and they wanted to see pain freedom at discharge. And so here are the data, the study here across 3 studies, pain-free at discharge was 66%. And essentially what they came down to is Ketorolac appears to be a safe and effective option for managing acute pain in the pediatric population. The results indicate significant pain reduction and a relatively low risk of adverse events. However, we do need randomized control trials to validate these findings and establish appropriate dosing regimens. Dan, when we have a kid out in the field that's injured, we want to try and reduce the amount of opiates that we use because we want to keep their respiratory drive intact. Toradol is kind of one of the newer, fancier things that are out in EMS. We use it for adults that don't need opiates, and this kind of supports using Ketorolac. I think it stands to reason that it has a high safety profile, but it kind of looks like it's time that we start using this for kids.
Yeah, I really like this study because, you know, I like meta-analyses because it looks at a lot of different studies and kind of puts everything together. Ketorolac or Toradol, it's an NSAID, so non-steroidal anti-inflammatory. You know, nobody wants to see kids in pain, especially. And you know, we're all a little concerned, I think, from the pediatric perspective, when we have kids that are in pain, that we're giving them opioids, because then, of course, we worry about airway, we worry about respiratory depression. Yes, we have other agents that we can play with, but this might be a really good study to spur involvement in RCTs, which we know are the gold standard, you know, for finding out research. It makes sense. It seems reasonable. It sounds like it's a safe thing. This is something I would bring to my medical director and definitely talk to them about, or my clinical people, because this sounds like a possible solution to a problem that we all deal with on a regular basis.
No, absolutely. And, you know, the simple question is, if the patient has pain, what do we do to get rid of it? Right. And in the adult population, we see patients all the time. They can usually handle whatever aliquot you want to give them of, you know, morphine, ketamine, fentanyl, you know, whatever you have available to you. You're always concerned with pediatric patients because pediatric patients present differently than adults, whether we want them to or not, right? And one of the biggest problems with pediatric patients is when they decompensate, they tend to do it late and fast. So if you have a kid that's in a traumatic scenario and you're not really sure what's happening with them physiologically, giving them an opiate can actually kind of mask that late effect, you know, crash this patient might have. So one of the things that I like about putting Ketorolac out onto the trucks for pediatric patients is it kind of changes our decision tree, right? Where if I have a patient I have a pediatric patient with an extremity fracture, right? Let's keep it nice and common, right?
There's hemodynamically stable, mental status fine. This is a kid who fell at a soccer game and broke their leg.
Right.
Absolutely.
And there's a different conversation. In New Jersey, we work in a 2-tiered system. So whether or not a paramedic would even get to a child with a broken leg is a whole different conversation. But
maybe
when you get there, right, whether or not you were dispatched appropriately, you're there, right? This is a patient population where, all right, now I have this option. I can give Ketorolac and not have to worry about whatever downstream side effects they might have, and have them have pain resolution by the time they get to the hospital. The dosing is pretty easy. 30 milligrams in most kids over 50 that are up to 50 kilograms will last 6 to 8 hours. Right.
That's
so you're also not worried about the drug metabolizing and then getting back into pain. So, excuse me, when we put Toradol out onto the medic trucks, it was primarily for the adult population. And that obviously
Right.
adults are who we see more often than not. So I think having that available as part of your arsenal of how I'm going to treat this patient is very important. For the pediatric population, now I think it's kind of like this might be for all pain management,
Mm.
save, burns. I think we can use this as at least a front line, right?
Mhm.
Because there shouldn't be any interactions between Ketorolac and any other analgesic that you might give. And again, it's another thing to explore, especially in children, is the patient's affect, is that a
Mm.
byproduct of pain, or is it a byproduct of anxiety from the pain they're having, right? Where when you have patients who are just kind of like, like whiling out on the stretcher, like, it hurts, how much is it of it is the actual pain or the reaction to the pain? And something like Toradol, you give that, they're not going to have a change in mentation. You might be able to see some of that pain resolve and then have that anxiety resolve as a byproduct.
Listen, I agree with you 100%. And I think that until we get Penthrox FDA approved as the green whistle, I'm a huge
Mhm.
fan of. Ketorolac is a really good option to not alter their sensorium, to not alter their mental status, but take away that pain. I think it's a win here. I
Yeah.
think that this would change my practice. This would definitely be something I would talk to a doctor about. Um, if it's somewhere where I suspect someone's bleeding, obviously not.
Sure.
But for your isolated extremity issues, I think this is a win.
And I think that's right, where this is something that is done in hospital already.
Mhm.
And it seems to me that if we're going to be treating patients in the field, we should be treating them as the hospital would be treating them.
Sure.
And this is a setting where, and again, I think about patient management in the back of an ambulance,
Mhm.
right? Where I don't have to calculate dosing for this patient. I give them 30 milligrams of Toradol. And so
Mhm.
that's a cognitive offload for me, but also I can maybe start to at least touch this patient's pain,
Mhm.
right? Where
Yeah, and
you want the goal to be, obviously you want the goal to be zero pain, but if I can get it from 8 to 3, where now
go
my
ahead
patient
and
is
begin.
breathing more effectively,
Absolutely.
I'll take that W.
And yeah, and think of it as a home run. Like if I give the Toradol, I can still give fentanyl. I don't have to do it right away. I can
Mhm.
try the NSAID, see how it goes. If I get pain reduction and they're comfortable, not saying they're pain free. We're talking about comfortable. I think it's a win because then if they're not resolved, then I can go ahead with aliquots of fentanyl. I can keep them comfortable. And I think that's a big win, especially in pediatrics, because you get kids that are hurt, everybody's stressed, the parents are stressed, the kids stressed. Once you
Right.
take that pain away, you really reduce that stress level and you make things a lot easier.
Yeah, and it again, it's easier to manage the patient in the back of the ambulance too, right? Where I think a
Absolutely.
lot of times when we think about kids, we probably think about babies. Um,
Hmm.
and that's true. But I mean, consider your average 8 or 9 year old,
Hmm.
right? Where now, aside from being scared from the injury they've sustained, they're in
Hmm.
pain, they've got all these other problems.
Yeah.
So if you can reduce their pain, it also might add to that affective domain, right? Where now the patient might trust you a little bit more, and they might
Yeah.
just because you're there and you helped, that patient might be easier to manage. This isn't a diaspora, right? This isn't, okay, we're giving Toradol for everybody. And this isn't to say that this, RSI and opioid pain management don't have a place, but it might be that, all right, you know what? Maybe instead
Mm.
of leaning toward fentanyl for everything, maybe we start to think, all right, we give Toradol for extremity injuries,
We're
right? So
we're
you start there.
we're making a continuum of care, right?
Yeah.
We don't just start with the big guns.
Mhm.
Start little,
Yeah.
ice
You
pack,
gotta start small. Yeah.
positioning, splinting. Then we move to Toradol. Okay, it didn't work. Now we're going to move to opioids.
Right.
Opioids didn't work. Now we're going to move to
Move to
ketamine.
whatever.
This is what we've asked for years. And now we finally got it. And now the evidence is starting to back that up. I'm really excited about this paper. I hope a lot of people do RCTs. I hope we validate this. I think it's a big win.
And I think that's right. I think Ketorolac is a big agent that's out in EMS now. I think you're going to see a lot of research and data on it. And because you listened to the Monday Afternoon Journal Club, you knew about it first. Send this to your medical directors, send this to your clinical coordinators. Let them know that Ketorolac is out. It is being used now in pediatric patients, and it seems to be effective. Let us know what you guys think. Be sure to subscribe to all of our stuff here on YouTube. Check out the website, overrunems.com. Be sure to look at all of our content there, subscribe, and do all the things. And watch us on EMS1 as well for the Monday Afternoon Journal Club and the Overrun, Ed Bowder and Dan Schwester. And we will talk to you all next week.